Hello, everybody, and welcome to today's session Team Based Care, Interdisciplinary Team Communication to Promote Patient Safety. My name is Dr. Lynn Klima. I'm a nurse practitioner, and I've been in practice for over 40 years, spanning both acute care, primary care, and community based settings, including hospice and palliative care. I'm a clinical educator. I've been teaching as well as working with patients with complex chronic illnesses for multiple years now, and I teach both at the undergraduate, graduate, and doctoral levels. And I currently also serve as the Patient Safety Officer and Educational Consultant for QAPI Plus. So disclosures for today, QAPI Plus nor myself do not have any financial interest, relationships, or other potential conflicts with respect to the material which will be covered in this session. Just as a reminder, this course does not advice for any individual provider or situation. You always want to consult with your company's legal or compliance personnel with any questions or concerns related to the subject matter. All right, so our learning objectives today are to discuss the approaches to effective team based care. We're going to spend a fair amount of time talking about the SBAR model and identifying each component in its purpose in healthcare communication. We're going to talk about common barriers to communication in home care and hospice settings and discuss strategies to overcome them. We're going to apply that SBAR framework and talk about them related to a couple of simulated case studies, and we're going to develop a personal plan to improve communication skills. All right, we're going to start off with a what is team-based care, and in 2010, the World Health Organization defined team-based care as a collaborative practice where multiple healthcare workers provide comprehensive services across settings. Right. So when we think about the four key principles, are shared goals that all members know the patient's care goals, that there's clear roles, that each discipline scope is understood by everybody. There's mutual trust, so there's that psychological safety that enables open dialogue and effective communication, which is structured, timely, and closed loop. So, because we're in a space where we work together across interdisciplinary teams in multiple settings with the patients that we're caring for, we're really going to focus today on how we work together as a team and focusing on communication. All right. So when we think about team communication, it's often taken for granted. It's an activity that, we really sort of focus on it only when we notice that something has gone wrong or we had an incident take place. We know that our patients are more complex than they've ever been before, and the way we provide care and where we provide care also makes it very complicated for us. So when we think about, the interdisciplinary team, effective interprofessional practice requires that each member understands their own role and the roles of others. So I encourage you, depending on where your work setting is, to really get the time and the space to understand who are each of the team members that are working in your practices or supporting your practices and what their roles are. And we don't want to forget the patient and their family who are a member of that interdisciplinary team, right? They're right at the center and all the different roles, right? So I mentioned that I worked in home care and hospice. So in hospice, we have nurses who function as case managers. We have pharmacists that support us. We also have physicians or nurse practitioners or PAs. We also have a spiritual care advisors or chaplains. We have social workers. So there's a whole gamut of people that we're collectively working with when we're working with these patients. And then you add volunteers into that mix, the family caregivers, so there's a lot of people that are involved, right? And when we think about interprofessional collaboration, we know that it's important to collaborate together, communicate with each other so that we can have good patient outcomes, some of which could be just better symptom management for our patients, more alignment with their goals and what matters to them, reduced hospital admissions, better safety profile. So it behooves us, it's in our best interest to really think about how we collaborate now, and do we have some opportunities to really shore that up or strengthen it a little bit more so that it's better. I want to speak a little bit here first about just the patients, right, and their families, the caregivers. We want to make sure that we're including them, and when we talk about engaging patients, really what patient engagement means. It's an increasing shift from a more paternal model of care where we're telling patients what they need. It's to one where we're really partnering, right? So they are a part of that team. And in a collaborative partnership, we want to think about how that can help them make better medical decisions. It really promotes that autonomy in terms of their choice. It helps them learn what they need to do if they're in the space to manage their conditions. And make sure that they're involved and interested in supporting their care. We also have to think about their family members too, and we want to make sure that we're also including them, and we want to foster that involvement, right? And by fostering that, it does start with communication, asking them what their preferences are, really listening to them, speaking them to speaking to them in language, in plain language terms that they can understand, giving them the time and the space to be able to consider and think about questions, encouraging those questions, and then making sure that, we are individualizing that communication, their preferences, and the way that they want to receive information that's relevant to them, right? So some patients are more electronically or technologically savvy, others are not. They like that, one on one communication. So it's really important, especially when you think about all the ways that we deliver care, that we can support them. All right, so let's kick off communication. Why does it matter, right? It seems sort of tongue in cheek to even bring this up, but when we think about just in terms of the safety profile and why does it matter, communication breakdowns are the leading cause of preventable patient harm. Every care team member plays a role in safer communication, right? So some of these statistics here, one by when we think about the Joint Commission, we all are somewhat familiar with them, reports that communication failure is the most frequent root cause of sentinel events, so those events that or incidents that cause direct serious injury to a patient or potentially even death. And then also when we think about where we're at in terms of home care and hospice, communication is even more critical. We work in isolation. We often don't necessarily have real time backup. So think about as we go forward, have you ever experienced a situation where communication and its gap affected patient care, right? Just reflect on that for a moment. So again, number one, communication is the leading root cause of sentinel events, and then teams with structured communication are 2.5, so 2.5 times more likely to catch near misses, right? And 80% of serious medical errors involve miscommunication during transitions. So I think about where I've worked and getting patients from the hospital, maybe transitioning somebody from LTAC to hospice within LTAC, maybe somebody in primary care switching over to a palliative care team or to a hospice team, right? We patients going to the ER. We have a lot of transition points for our patients, multiple specialists, right? Our older patients tend to see several different providers. If you're in that home care space and you're trying to wrangle all those different components of what you really need to do to support that patient in their home, right? So 80% of serious medical errors involve miscommunication during transitions. So again, that's really a hot handoff opportunity. We talked about that. All right, so importance of team communication. So again, we talked about the Joint Commission. We also know that diagnostic errors are common. I'm just bringing this slide here. This is from the Agency for Healthcare Research and Quality, because when we look at where those errors take place, those communication errors, outpatient, right? So we sit in that space. I often think, oh, it's the hospital, it's the acute care where a lot of errors take place. It is in the outpatient space, which is where we are. So it has an impact on patient safety, if we maybe have inappropriate testing, wrong treatments. It's very expensive if we're not all on the same page in terms of what needs to happen with our patients. All right, so now we're going to talk a little bit about just ways that we communicate together. All right, so this is a slide from Agency for Healthcare Research and Quality and their Team Steps program, and I'll have these materials in your learning platform for you so that you can also reference them. But they have some great resources, and we're going to talk about them today in terms of standardizing our communication approach so that we're using evidence-based tools in a way to promote safety. So effective communication is critical, not only for safety, but to provide high quality care. And it involves not only sending and receiving the message, but also the shared understanding of what that message was, what was intended in that message. And that can sometimes differ from the intended message, right? If I tell somebody this is what I need from them, and I kind of have a clear idea in my mind, but I don't take the time to make sure that they understood what I meant, that can create issues on the other side in terms of how it gets handled, completed, acted on. And we also know that communication can be influenced by noise, the context, the assumptions of the people that we're working with, that can all impact the clarity and effectiveness. And so, Team Steps and the Agency for Healthcare Research and Quality have designed some important tools I think that are very helpful for us. So, we're going to think about and talk about how we can apply them in our practice. We also want to just be aware of how we practice together, right? There are different ways that we communicate, and it's not all verbal, right? We think about all the tools, our documentation. If you have morning stand ups, if you have weekly IDTs, you also likely have policies and procedures and agreements. Maybe you have standing orders. We also have meetings. So there's a lot of ways that we share information with each other, and it's not always just in the verbal way. We also use a lot of informal things, right? Or technology that's sort of come front and center for us. You might be using messaging, Skype, Microsoft Teams. Maybe you're using some type of a texting app if you're out in the field. You also have, just phone conversations. You might also do some virtual stuff, right? Not only with our patients, but maybe with each other on your team. I know more of us have in our stand ups are doing Zooms or Teams meetings to kick off our day. And then phone conversations, right? Or telehealth kind of visits. So there's a lot of different ways that we communicate with each other. Thinking about what you have in your organization or how do you work together. And all these tools serve a different purpose. They're all meant to keep each other informed of what's happening with the patient, the plan of care changes, any operational changes that support better patient outcomes. But we have to know they're there and we have to access them and make sure they're current, right? So I think about standing orders, some of the standing orders that we have in our organization are transitions of care, follow-up calls. What do we do when a patient transitions from one setting to another? How do we respond to patients? What does that call look like? How frequently should they have if it's an admission or a follow-up with a symptom? Maybe we're working with suppliers, DME or pharmacies. Maybe it might be referrals to team members, right? So, what are those things that you have in place that share how you're going to communicate, the timeliness of that communication, what needs to be included, what needs to be documented? So, lots of different ways, right? And I don't think we realize, we're busy handling a lot of multiple tasks, and these are all ways that we could impact our ability to have that nice, clean communication loop. Here's some examples. Again, these vary with organizations. You might have a stand up, a huddle, an IDT. Those are very patient focused, updating the plan of care. And then you also might have formal meetings where they're operational with changes and things like that. So there's lots of ways to be able to, and even patient care conferences, right? So there's lots of different ways that we can communicate. We also want to make sure that we aren't forgetting the digital age, right? We're kind of front and center in the middle of this, right? So video conferencing, social media platforms, instant messaging, email communication, those collaborative documents, right? Any of the things that might be in writing or policies and procedures. So lots of different ways that are, on that information highway, sharing us what to do. The other part of communication that we want to be aware of is nonverbal communication. So we talked about the how and the ways, but we also want to make sure that we're considering nonverbal communication because it plays a crucial role in how we convey and interpret messages, particularly if you're face to face or have the opportunity to visually see the person that you're communicating with. So body language, tone of voice, facial expressions can either enhance or undermine the effectiveness of our communication. And so being aware of the nonverbal cues that can provide valuable insight into how a person's feeling, their intentions, their level of engagement. I think we do this a lot with our patients, right? How we're assessing them and how they're feeling. And they may not be saying the words, but we can evaluate them based on the visuals, what we see. Also important to be sensitive to common barriers to effective communication. Some might be our own the hierarchy, right? um, when you are worried about speaking up because you don't want to be punished, right? It's the single most important team factor for quality improvement. As leaders, if you're a leader on this call, you want to make sure that you are opening the door for open communication and safety, that people can speak up. So a lot of times people, if I'm a home health aide in the field, they might not feel like they can speak up on some of the things that they might be seeing because of that power imbalance or that perceived power imbalance. So how we structure our communication is important. Where we talk to each other, right? So environmental barriers. A lot of times in our space, we're working alone in the patient's home, out in the community. We might also have unreliable phone or technology access. There might be a lot of distance between team members. So, this might be, more important when we're relying on some of those structured tools to be able to help communicate with each other. There's also patient and family barriers. In a future session, we're going to talk about health literacy, but 36% of adults in the United States have below basic health literacy, which is about that middle school level, fifth, sixth grade. And, how we talk or speak and make sure patients understand the directions or the information that's provided to them or given to them in a way that they can understand is very important. And then organizational barriers, right? So when we think about schedules and where we're doing visits and what are our processes to communicate with each other and our documentation systems and our caseloads and the volume, all of these things can be barriers to how we communicate with each other. It doesn't mean they're bad or wrong. They're just things that we have to consider when we're thinking about those that how we approach communication. Some others are, in terms of personal. Maybe you're stressed, your anxiety, maybe you have memory limitations, maybe you're tired, you're not feeling well. All of us are multitasking. Also, maybe we're new to our role, new to our team, or we might have those, flawed assumptions about those other people on our team. What do they do, or how do they do it, or even flawed assumptions about patients. And then the environment, right? So we talked already about modes of communication. They're rapid, multiple different places. We also are under time pressures, constraints. Think about us in the field driving. That's also another constraint. Distractions, interruptions, and then even just variations in team culture and the people that you work with. Everybody sort of approaches things differently. Just a couple of highlights specifically to home care and hospice, right? So, geography, where we're providing care and how each of us or where each of us is very, challenging. We also work with a diverse group of team members, right? We have a variety of professionals and support staff and volunteers, and the patient, again, and family member are part of those care teams with us, so that can be a problem. Language and cultural barriers. So families might come from different cultural backgrounds, speak different languages, have different beliefs. So that can be a challenge. Um, emotional sensitivity when you think about some of the topics or the space or the complexity of the patients that we're working with. These are really sensitive topics, emotionally charged, necessitating that we are available and present and empathetic, but we're also, in a space where we are able to support patients and recognize that their stress and anxiety, as well as their family members, is going to be much higher than we might normally anticipate. And then our own, sensitivity when you're taking care of patients who are declining and not doing well. That is also, something that's really challenging. And then technology, right? The internet always doesn't work. Technology doesn't work. It can really hinder real time, timely communication, collaboration, information sharing. All right, so let's think about now what can we do, right? Let's kind of start from the beginning. Now we know that communication is important and why it's important when we work with all these team members, but it's also it starts with relationship and engaging with each other, right? So effective teamwork evolves over time, and it's enhanced by a conscious effort to get to really know each other, right? And if you're new to your role, orientation is a great time to shadow team members, learn their names, honor their expertise. If you're in a management position and you're organizing orientation for people, this is a great way to be able to make sure that they have a chance to shadow. Um, again, just to be able to see what the other person's, roles are doing. Also, if you're in a management position, maybe having team members shadow you too, so they can see things on the other side. So, seeking those opportunities for interactions or building those opportunities if you're in a leadership position, be curious, recognize common goals, right? We're all there to be able to help the patient, but sometimes in the way systems are set up or the way things happen, it doesn't always feel that way, and so we don't want to be angry or upset or blaming of each other, but just recognize that we all have same common goals and values in terms of why we're working in the space we are to support those patients. And so coming from a place of good, right? That's where what people are trying to do. We also communicate differently. We have different styles, making sure we recognize that. Try to be proactive and just assume the best, right? So starts with just that relationship with patients or people, patients too, but team members. And then thinking about our listening, right? So not listening to respond, but really active listening, focusing on the speaker, making eye contact, try to avoid distractions. I know that's really hard to do when we're virtual. It's real easy to try to have like a little notebook open or something else, doing something else and planning your day when maybe you should be fully present, focusing on the speaker. Trying to avoid interruptions, refraining from, interrupting the speaker, instead waiting, for them to finish their thought before responding. Paraphrasing and summarizing. So again, restating what you heard in your own words to ensure that you understood the message. Ask clarifying questions if something's unclear. Be polite, right? So respectful of each other. No, doesn't matter who your or what your role is on the team, and then be empathetic, right? We want to be able to make sure that our team, as we're working together, we, support each other and we appreciate each other, and, we want to be able to be respectful of each other. All right, some strategies to overcome some of those barriers are, again, using inclusive language, making sure that we're creating a safe space, normalize speaking up, respond positively to concerns, never punish questions, right? And so I say this to you, leaders on this call, in your team meetings or when you're working with your staff, open the door to those questions and be open to each other's questions. Second is using that closed loop communication, right? Remember that we're sending information, the receiver gets that information, and they can clarify and ask questions about it so they can repeat back to you, and then you as the sender are confirming that. We want to make sure that we know what to do, when to do it, how to do it, and we're closing that loop. Use your technology wisely. We have, that's not going away, but what are those tools and when are they appropriate to use? And make sure that everybody has the availability on platforms and knows how to use it. Using plain language and teach back. I say this in terms of using for us, right? Making sure that we're, directly speaking with each other and, communicating clearly, but also to our patients and to those caregivers and having them, you know, um, you know, demonstrate back to you. We're going to talk about teach back as we go forward. Having structured handoff protocols. So I'm going to give you a couple of examples through the ARC um, evidence-based care toolkit that we're sharing with you, and then cultural humility. Asking about preferences with each other, but also with patients and practices as well. Right? We want to make sure that everybody supports and is, you know, um, supportive of each other and what's important to them. All right, so now let's talk about the tools. And some of these you may have seen before, but it's just a good refresher to say, are there some of these that we can use in our practices or that I can use in my practice? So, closed loop communication, right? So, this is what we just talked about, that we're sending the message, we're making sure the person receives the message, they are able to clarify or ask questions about it, and they know what to do with it. And then once they act on what that message is, they're circling back around to make sure that we know that loop was closed, that task was done. Team Steps identifies this series of uh, standards in our communication, that it's complete, So it can, communicates all the relevant information, that we're conveying information in plain language, so a way that the receiver can understand it, whoever the receiver is, that it's brief, right? We want to give the most appropriate information in as concise a way as possible. A lot of us work with very complicated patients for months, weeks, and so it is not always necessary to tell the whole story, like what needs to be pulled out of the story in that communication. That it's timely. If it's something that needs to happen quickly, that I'm not waiting until the end of my day or the next day to be able to share that. I'm, promptly, working on communicating that, and also asking for a time frame back when I need it. If I need it tomorrow, if I need it by the end of the week, if the patient's expecting something today, whatever that time frame is, so that the receiver knows where to process that in their workload. And again, being respectful, so that we make sure that we are respecting each other. So this is the team steps model. It's an evidence-based framework, and it's meant to optimize team performance across the healthcare delivery system. So it doesn't matter where you're working, but it talks about, how we're led, situation monitoring to make sure we're doing things okay, we're supporting each other, how we're communicating, and again, the goal here is safe, efficient, patient-centered care. First tool we're going to talk about is SBAR, and I'm sure this is one that is at least vaguely familiar to you, if not very familiar to you. So SBAR stands for Situation, Background, Assessment, and Recommendation. And we're going to talk a little bit more about that in detail. This is a way to be able to make sure that when we're reporting off to different people, providers, community providers, if we're interacting with them, specialists, whoever we're working with in that medical neighborhood, that we're using an approach to be structured. What's happening with the patient? What's the background or the context? What do you think the problem is? And what's the recommendation, right? What do we need to do to correct it? Another one is check back, and it's also sometimes called repeat back. So, again, this helps us think about closing that loop to ensure that information is conveyed by the sender is correctly understood by the receiver. So, here in this situation, the doctor's saying, please share this information on cholesterol with Mr. Garcia and ask him to come back for a follow up visit in a month. Mary says, confirmed, I'll share the information. She's basically repeating back to him, and Dr. Moss says correct, right? So again, it's closing that loop. And when you think about how we submit information to each other, it's very one directional, right? We're sending a text, we're sending something through the portal, we're documenting something in the record. How do we know the other people on the other side? So checking back to clarify, it's a good opportunity. Now there's handoff. This is very important as well. It's just the transfer of information during transitions across that continuum. So it includes the opportunity to ask questions, clarify and confirm, relevant during shift changes in the hospital, but also transition between care providers and home care teams, hospice teams, between departments. It can be done virtually or with an e-handoff function, like an electronic health record. So in a handoff, you're, transferring that responsibility and accountability, the information, the verbal communication of information. You're acknowledging it by the receiver and then an opportunity to review it. So again, and when we saw that error, 80% of errors take place because of those transitions. This is maybe an area to sort of shed some light on. This is one of the tools in that toolkit. It's called the IPASS, where that's the acronym: the illness severity, the patient summary, the action list, the situation awareness and contingency planning, and then the synthesis by the receiver. So, again, what does your transition look like when you're doing a handoff, and how does that work? Teach back, probably familiar with this one. This is not new. This has been around, as long as I've been in nursing school, right? Where we're asking the patient to it's really to support them to be able to help understand if they understood the directions, right? So we want them to have, and their family, the information in a way that they can process it. And this gives us an idea of, did they get the information, right? They explain it back to you or they demonstrate it back to you. It's a way to confirm that how we've explained or demonstrated to patients that they understood it and they are able to act on it, right? Because they're going to self manage, and we want to be able to support them. So those are the tools that are out there. Now we're going to talk a little bit about the SBAR communication model: situation, background, assessment, and recommendation. All right, so why do you even want to think about SBAR? And there's one thing that you take away today: transition, but then SBAR. I think two tools that I think are important to really think about how you can strengthen within your practice and within your organization. So the benefits of SBAR, we know from the literature, it provides a standardized format for communicating critical information and ensuring important details are not overlooked and reducing the risk of miscommunication. So it reduces errors. It enhances patient safety by promoting concise and focused communication, helping improve outcomes. It improves team collaboration because it gives us an opportunity to provide a structured process with each other, enabling us to be able to work together more effectively and make informed decisions for patient care. And ultimately, it improves those patient outcomes. So, lead to better, accurate diagnoses, symptom management, timely interventions, and better overall patient care, resulting in improved clinical outcomes. These are some statistics in terms of, where we have opportunities with SBAR, right? So when we think about readmissions, that's an opportunity to prevent readmissions. Symptom management, again, this is a big space for many of us. What can we do to manage those symptoms, improve satisfaction, and improve patient adherence to their treatment plan? So let's talk about a couple of different case studies here. So in home care, improving communication in home care. A home care agency implements SBAR to enhance communication between nurses and physicians. This resulted in reduced medication errors, faster response times, and improved patient outcomes. So this data is coming from Agency for Healthcare Research and Quality in terms of studies that were done to be able to validate why we would want to do this. Um, Enhancing hospital handoffs. The hospice organization utilized SBAR to standardize the handoff process between nurses during shift changes and back to and then into the hospice. And this led to a more comprehensive patient information transfer and reduced adverse events. Reducing hospital readmissions, we talked about that. The collaboration, helps with knowing what needs to happen, and we know within that first 24 to 48 hours after a discharge, a patient is very vulnerable to be readmitted, particularly those with multiple and complex chronic illnesses. Also empowers caregivers, right? And if we're using, and this is a great space to teach patients and families how to use this language too, so that they can tell us what happened, what's the background, what are you seeing happening, and what are you recommending, what do you need, right? So that's a good way, and then it just streamlines, communication across team members. So there's a lot in the research, a lot of studies that are out there, and they're in the reference pages for you to just validate that this is good practice. So this is SBAR again, what's happening right now, making sure you're saying who you are, who the patient is, and the immediate concern. What's the context, any relevant history, diagnoses, meds, vitals, care plan status, the assessment, what do you think's going on, your clinical judgment of the situation, even you're uncertain, right? I think maybe it's this, they're struggling. If you're a medical assistant or a home health aide, sometimes they don't feel comfortable sharing, but you know what you see, you know what you heard. This is a good opportunity to share that. And what's your suggestion? So this is again an area where we feel like we might not always have the power or the authority to do that, but I think another visit needs to happen, or if you need somebody to see them, or can you just kind of take a look at this, or if you need something else like another referral, providers appreciate that. They tell us that it's really important to have the recommendation, so they're not there then trying to guess what needs to happen. So be direct. Don't make the receiver guess what you need. Okay, we're not going to watch this here, but it is in your resource packet. This is a demonstration of an effective SBAR that's done between a pharmacist and a provider in an acute care setting, but it is actually just a nice kind of way to see. It doesn't take a lot of time, just takes some preparation, right, to be able to be ready. So here's an example of a case study of an SBAR in action. So in a healthcare team meeting, so let's just say it's, an IDT, a group of healthcare professionals, get together to discuss a patient. They have an SBAR worksheet. So in their IDT team, they're using that worksheet to be able to dialogue with each other. So where I've worked, every team member kind of does that, and they prepare their SBAR like that, so that we're not just kind of chatting it up, which can happen, right? So it kind of keeps us very focused. And then we review the patient record at the same time to make sure if there's anything else that needs to be adjusted or done, have a collaborative discussion, and then make any recommendations or changes that's needed, right? So it's a way in our space to be able to how, instead of just that individual group, how we can also use it within our um, interdisciplinary team meetings, which we have. This is also sort of a process to be able to think about if you're in a leadership position, how you might think about using SBAR across the organization. So first evaluating, and are there any barriers and facilitators to be able to get it going? How do you set it as a standard, right? I guess if I'm a leader, I'm thinking about what can I do to assure that we're encouraging this process and role modeling it, and then have a plan. What are we going to do? How are we going to use it? What training does staff need to feel more confident with it? And then how are we going to support them, right? We have to buy into it as leaders to be able to encourage it, making sure that we're incorporating it into our workflows as well, and asking for it. So let's use an SBAR, bring out those pieces of paper, in the meeting. That's what we did. That sort of helped get people sort of ready and prepped and ready to go. And then evaluating it, right? So that process improvement. Are we using it? Is it working? And where have we seen some opportunities? So here's a, home care and hospice situation. So when we think about Maria is the home health aide for Mr. Torres on Oak Street, and I'm calling because he fell this morning trying to get to the bathroom, and he is alert but shaken. The background is that Mr. Torres is 82. He has a history of falls and is on blood thinners. His last nursing visit was 3 days ago. His wife said he seemed weaker than usual yesterday evening. She says in her assessment, I checked him over, no visible injury, but he's complaining of left hip pain, and I noticed his blood pressure was lower than his usual. He doesn't look right to me. And so her recommendation is I think you should come assess him today, or should I call 911? His wife is very worried. Please advise me on what to do next, right? So she offered a couple of different options and acknowledged the family's emotional state, right? So I think, when you're thinking about your support staff, right, home health aides and non clinical staff should be also feel empowered and trained to use the structured approach within the scope of their roles, right? So that they are able to know what to pull out, and we practice this, right? So that people get more comfortable with pulling out what needs to go in each of those different areas. Also, if you're a provider in this call, it's good to maybe there's information you want to make sure that people are getting, so that you can include that. We've used SBAR that way too. When I'm going to present a patient, what do you want on this end of it, so that I make sure that I look for it and get it and have it available, so that we're not, floundering to try to find that detail later. There are a couple of case studies in here. Here's another one here. You're an LPN conducting a routine home visit for Mrs. Chen. She's a 68-year-old woman who had right knee replacement 10 days ago. When you arrive, she's sitting on the couch and does not want to do her exercises. She says her knee is really sore today, and it looks more swollen than her last visit. Her temp is 38.4, and the surgical site has increased warmth and redness. Her husband is present and seems worried she's on a blood thinner. So when you're going to do this SBAR, you're going to again pull out who's the patient, what's the background, what do you think's happening, what's your clinical concern, and then your recommendation. What do you need from the nurse to be, to be specific and direct. Don't shy away from it, right? So if you're the LPN, you're saying I'm calling because I'm, my name is, so and so. I'm the LPN that's caring for Mrs. Shen, and I'm calling because she may have a surgical site infection. Her, temperature is this. Her increased redness, warmth, and swelling, is is this. She's on an anticoagulant. I'm concerned this may be a surgical site infection or a DVT. Given her symptoms and elevated temp, I need you to come. My recommendation is I need you to come assess today or advise me on whether to send her to the ED. Please call her surgeon. Right. So you don't want to have a vague opening. You don't want to bury the critical concern because this is a concerning situation. Don't avoid saying it. And it's also helpful, I think, just saying the situation is, the background is, the assessment is, or my assessment is, and here's my recommendation, or this is what I need from you. There's another one in here on end of life pain management. So these are a couple of examples that you might want to pull out into your team meeting or create your own. Just use some samples in your IDTs this week, right? What is a patient that you could practice using the SBAR? And then, debrief, what worked really well, what elements were, clearly communicated. Sometimes people put in too much, right? So it's an opportunity to evaluate what was challenging. Sometimes it's hard to put everything together and not tell the story. We like to tell the story, so that could be hard. What would you like to change, right? How do you get better at it? If you repeated the scenario, what would you like to do differently? And how does this apply to your practice? Name one real situation where using SBAR would have changed the outcome. So I encourage you guys to use this content. You have the PowerPoint, you have these case studies to just, kind of start thinking about and practicing using SBAR and getting more confident, and then reflect on how are we doing it. So it doesn't happen unless you make a commitment to do that. And some of that, it's just learning without application. It's just information. So let's think about what you can do to make it personal. So as an organization, I would encourage you to really look at your opportunities to embed this into your workflows. As an individual, what do you do now? What's your current state? What do you struggle the most with? Rate yourself 1 to 10 on each of those different components, and then set some goals, right? Set some SMART goals. I want to use an SBAR in every phone call to the physician. And so, you'll track how many calls this week, and, maybe you're going to commit to doing this for 2 weeks and then see how it goes. Identify your barriers. What makes it hard? Is it anxiety? Is it your habits? Is it the time frame? Is it support? Do you need more support and mentoring to be able to do it? Are there environmental changes that need to help happen? Right, again. So, what are those things that are going to trip you up to be able to achieve your goals? And then, what are some of the resources? So, I've provided the toolkit, but I also, like I said, I teach nursing students. So have a little pocket card right at every visit or taped onto your laptop. Practice it in non-urgent situations, and then look at those modules or resources that I've put together for you. So, just in terms of thinking about opportunities here, and concluding, a key takeaways is that when we think about our teams, we require that active collaboration with each other, um, in terms of our shared goals and mutual accountability and caring for our patients. And we want to make sure that we're cohesive in how we work together, and communication is a big piece of that. And we know that communication failure is a leading cause of preventable patient harm, and we all play a role in safer communication. One very effective strategy is SBAR. It provides a universal language for all healthcare team members across all settings. And then we know that barriers to communication can exist, whether they're hierarchical, environmental, patient, or organizational, and they can be overcome with structured tools and a culture of psychological safety. And then skill development requires deliberate practice. So use your personal action plan with SMART goals to continue improving after today. That's all I have. There's some references for you at the end. But thank you very much and have a great rest of your day.